that is evolved newly for over the past few years for low-risk MDS in general. So I would like to talk about an update in the classification of myelodysplastic syndrome, and also there is a recent update in the risk stratification. Some of them are really, really recent over the past few weeks, and we'll talk about some of the data that was published recently, and followed by a goal of therapy for low-risk MDS, specifically on anemia, and also the available therapy for low-risk MDS with focus on anemia. So in terms of classification, more recently over the past 1 or 2 years, there was an update in terms of classification of MDS from the ICC and also the WHO. Both published and updated data for the MDS and MDS classification. As you can see, the lineage classified by lineages, classification by lineages was maintained in the ICC for single lineage and multi-lineage. However, in the WHO, the lineage was removed from the classification and replaced by morphological defined and genetic defined. Morphological defined, the ICC maintained the excess blast, anything of 10 to 19%. And they also, for the WHO, they have multiple definitions for morphologically defined MDS, including low blast, hypocellular, excess +1, and or increase +1 and increase +2, and also they incorporate MDS fibrosis. For genetically defined, 3 major things, which is known to all of us, which is SF3B1 mutation, and 5q and biallelic TP53 mutation. And each one they classified in a slight different way from the other. Of course, MDS with the ring sideroblast, if the SF3B1 is mutated, it will be called immediately MDS SF3B1 without the mention of the ring sideroblast. In terms of prognostic models for the myelodysplastic syndrome, this has been evolved over the past many decades. And 10 years ago, the IPSSR was our standard of care to classify those patients and then to decide which one of them will go for more intense therapy in terms of curative allogeneic transplant, and or those with low risk MDS that they will be only for supportive therapy. However, more recently, the molecular data was incorporated into the clinical and cytogenetic data to define, to better define those with high risk MDS and also low risk MDS. So what's basically the molecular IPSS is incorporating more genetic or more genetic mutations that help defining the IPSSR. And this is based on complex Cox regression model that help in the calculation of this model. This is an example for the website that can be used to calculate the model. Basically, you can enter the clinical data of your patient with the cytogenetic data and then answer the molecular data. It's involved more than 16 or 17 gene. Whether this is gene mutated or not, then it can give you the final result with the associated clinical outcome in terms of overall survival and event-free survival. Why the molecular is important? Because We know MDS is genetically defined disease and associated with multiple genetic mutations that can present in different frequencies among patients. The most common one is TIT2, followed by SXL1 and SF3B1 and so on. And in this data, for example, presented here, the more driver mutation the patient has, the worse the leukemia-free survival for
do we have a problem with the connection? Or?
دكتور بدر
Do you hear me now?
Yes.
Okay, excellent. Sorry for that. So the more genetic mutation the patient has, the worse the outcome for the MDS in general. The IPSSM helps in whenever you apply this compared to IPSSR, it will usually upgrade patient into higher risk. And this is because of the incorporation of genetic of the genetic mutations, and this has been validated in multiple cohorts using thousands and thousands of patients, and led to a better definition of those with the very low risk versus those with high risk patients. More recently, actually a few weeks ago, a nice paper published in JCO where a group of scientists, they actually analyze data for more than 7,000 patients, and they divide it into training set and validation set, trying to compare the decision outcome for strict transplant policy for those who use IPSSM versus IPSSR. And what they found that incorporation of the IPSSM score led to better definition of the optimum time for allogenic transplant. And as you can see here in the upper set, based on the age group, you can see that patients with who transplanted early at the time of the diagnosis, they actually have, this was actually associated with better overall survival compared to patients who transplanted in the later stage, and patients with low risk and moderately low risk when the optimum time was actually the delayed transplant policy for those patients. So the patient who actually transplanted early at their diagnosis with low or moderately low risk, their survival did not perform better in compared to those with delayed strategy. And this also has been shown for those with the IPSSR as well. However, when you compare them head to head within this study, they found that the using the IPSSM as a strict policy for allogenic transplant, they were actually able to downgrade around 15% of patients who used to be eligible for transplant based on the IPSSR. They become non-eligible for transplant, or they don't benefit from upfront transplant according to the IPSSM or molecular. And 19% who used to be considered to be low risk within the IPSSR, they were actually eligible for upfront transplant using the IPSSM. So kind of a better definition for those patients who will actually benefit from the transplant in the upfront setting. So talking about the treatment algorithm for patients with MDS. In general, you need to define what's the risk status of those MDS patients, whether they are low risk or high risk group. High risk group depend on the performance status and age. Those who are fit and younger, with less comorbidities, they will benefit from the upfront transplant, and this usually preceded by whether use of intensive therapy or hypomethylating agent, depend on the blast count initially, followed by allogenic transplant. While those who are not fit for transplant, the use of hypomethylating agent is the standard of care for those patients that usually resulted in prolonged survival and delayed treatment at MDS transformation. Patient with low risk, they should receive supportive care with specifically patient with specific patient with 5Q MDS, they benefit from lenalidomide. I think this is the standard of care based on multiple data which suggest the benefit of lenalidomide for this group of patients. And then there are some other talk that and focus that we will discuss about the use of newer agents such as luspatercept for patients with low risk MDS. So what is low risk MDS? Depend on what kind of prognostication score you are using. For the IPSSR, usually patients with very low, and some of the intermediate group, they consider to be low risk. And with the use of IPSSM, which that's what we usually do currently, is usually patient with very low, and moderately low subgroup of patients considered to be low risk MDS. What is the goal of care for low risk MDS? Is actually delaying the transfusion need or preventing the patient from the transfusion, whether blood transfusion or platelet transfusion, improving cytopenia, improving quality of life, preventing iron overload. So all these are considered to be the priority for the low risk MDS, while the priority for high risk MDS, of course, is the cure and improving survival, preventing disease progression. So anemia occur in more than 90% of patients with MDS, and resulted usually in significant increase in mortality. And as you can see here in the graph in your right hand, patient with anemia, they have higher cumulative probability of death. And this is usually a non-leukemic death. And it is likely due to the comorbidities and morbidity associated with frequent transfusion, including cardiac toxicity and others. And those who are actually transfusion dependent, low risk MDS, they have actually poor prognosis. This graph represents a group of patients who are within the definition of low risk MDS, but they segregated them into those who are transfusion dependent and those who are not transfusion dependent. And as you can see here, the graph clearly separated, not in favor of those who are transfusion dependent, and increased cumulative incidence of death for those patients is actually not related to the leukemic transformation, indicating the huge unmet need for such patient population and increased death related to the associated toxicity from the continuous transfusion for those patients. So what is the impact of iron chelation therapy for those patients? It wasn't really well defined up until recently. There was a multi-center randomized double-blind placebo-controlled trial, which they tried to answer this question. However, it wasn't really a full answer for the question of the major role of the iron chelation in this patient population. However, they enrolled around 225 patients with a high serum ferritin and high transfusion dependency, who has no baseline cardiac, liver, or renal abnormality, and they receive XJET oral versus the use of versus placebo. The primary endpoint was event-free survival, and the event consider any non-fatal event related to cardiac or liver dysfunction, or transformation into acute myeloid leukemia, or death, whichever come first. What they were able to show that the use of iron chelation definitely showing a control of the ferritin level and showing and a decrease in ferritin level over time. And also there was significant improvement in the event-free survival. However, due to the reduced patient enrollment, it was proposed to have to enroll 600 patients. However, they were only able to recruit 210 patients. So this was insufficiently powered to detect any overall survival benefit for the intervention of the use of iron chelation in general. The erythroid stimulating agent is an important supportive measure for patients with anemia and myelodysplastic syndrome, and it's used to be the standard of care up until recently. Multiple data and multiple randomized study have shown an average of around 30% response rate for the use of erythroid stimulating agent, with a median duration of response ranging between 18 to 24 months, depending on the study used. And there are some data from like retrospective data and registry-based data showing even there are some improvement in the overall survival, but this is retrospective data and you cannot draw a significant conclusion from this. However, we need to improve over that, and we know that anemia is a major burden for those with low-risk MDS, and erythroid stimulating agent is not usually the solution, and many patients they cannot tolerate this intervention, or they are not eligible to receive such treatment. More recently, a newer agent has been developed for the management of anemia and low-risk MDS. Luspatercept is used for an effective erythropoiesis and associated with anemia. This is a first-in-class erythroid maturation agent. It's a recombinant fusion protein, consists of modified extracellular domain of human activin receptor type 3B or 2B that is linked to human IgA1 Fc domain. And what's this doing actually is bind to the to certain type of TGF-beta superfamily ligands that, and by binding to that, this will lead actually to inhibition of the activin receptor activation, and that will lead to a decrease in the SMAD2, SMAD3 signaling. And by this decrease in the signaling, this will lead to erythroid maturation. And what luspatercept focus on is actually the delayed maturation of the erythroid precursor. So EPO is working on the early stage of the erythroid precursor maturation. However, the luspatercept work on the late stage of erythroid precursor. This has been tested in a randomized study called Medalist study, which is a phase 3 double-blind placebo-controlled study evaluating the efficacy and safety of luspatercept for patients with low-risk MDS and ring sideroblast. And those patients should receive regular blood transfusion and had disease that is refractory or unlikely to respond to erythroid stimulating agent. Eligibility criteria was MDS with ring sideroblast according to WHO criteria. However, if the ring sideroblast is less than 15%, then there should be an SF3B1 mutation. Of course, there should be less than 5% blast in the marrow, no 5q deletion, and the IPSSR was very low or intermediate risk. And there must be a prior erythroid-stimulating agent response and exposure, and must be refractory or intolerant. And APO level should be, for those who could not receive ASA, their APO should be more than 200, and the average RBC transfusion burden must be at least 2 or more units per week. And there must be no previous exposure of hypomethylating agent or IMiDs. Patient randomized 2-to-1, luspatercept versus placebo. There is a scheduled dosing specific for luspatercept, which is a subcut injection every 3 weeks. And as you can see here, the median age was around 71 in total, and 71 and 72 between luspatercept and placebo. There was also around 70% of patients, they are actually IPSS-R low risk category, and 90% of patients actually they are SF3B1 mutated. And looking into the primary endpoint, which is the transfusion independent for at least 8 weeks or more, this has been achieved successfully in the luspatercept group, with 38% of patients they were able to achieve this primary endpoint versus 13 patients with those who received placebo, and patients who had more than 12 weeks of transfusion dependence were 28% in the luspatercept versus 8% in the placebo group only. And other secondary endpoints, including erythroid response, which has been achieved in 50% of patients with luspatercept versus 12% of patients with placebo. The adverse events, there was no major difference in terms of risk, progression into high-risk MDS or progression into AML, which was seen in 2% of patients in each group, in both groups. There was no difference also in thromboembolic or thrombophlebitis event, and no difference in death that is led due to the adverse event. There was an increase in the fatigue for patients with any grade of fatigue for patients in the luspatercept group, as well as increase in the diarrhea. Long-term data has been reported recently in the last ASH meeting, and this long-term data actually looking into an additional 26-month follow-up from the final data cutoff. So they kept actually the randomization unblinded throughout the extension phase for the long-term follow-up. So basically, at the time of cutoff for the long-term duration, the median follow-up was 39 or 40, almost 40 months for the luspatercept group versus 38 months for the placebo group. And you can see in the middle graph, patients who were able to achieve transfusion independence for 8 weeks or more has increased with the currently updated data compared to the previously reported data. So now 49% of patients with the longer follow-up, they were able to achieve the primary endpoint compared to only 15% of patients with placebo. And looking specifically only for those who achieved the response, around 41% of patients who achieve at least 8 weeks of transfusion independency, they were able to maintain their transfusion independency throughout at least for 1 year or more. And for patients who achieve transfusion independency for at least 16 weeks, 60% of them, 64% of them, they were able to achieve to have an uninterrupted RBC transfusion for more than 1 year, indicating an excellent duration of response for patient who received luspatercept compared to placebo. There was no new signal in terms of adverse event with the longer follow-up, especially in the progression to high risk or AML. And looking into fatigue, which was initially reported as a higher level, it was actually became almost equivalent with the longer follow-up for patients with receiving luspatercept versus placebo. Currently, the luspatercept approved for refractory cases, for cases refractory to erythroid-stimulating agent, and also has been recently approved in the upfront setting. So the COMMAND study was designed to answer the question whether the use of luspatercept in the upfront setting is superior to the use of standard of care, which is erythropoietin-stimulating agent. So this is a phase 3 open-label randomized control study, enrolled patient with low-risk MDS, and they enrolled actually MDS with and without ring sideroblast, who has blast less than 5%, irrespective of their SF3B1 mutation. And those patients must be patients who require blood RBC transfusion of 2 to 6 packed RBC per week, with a minimum of 8 weeks immediately prior to randomization. Their APO level should be less than 500, so they will be eligible to the use of erythroid-stimulating agent. They should be an erythroid-stimulating agent naive. Patients were randomized 1-to-1 between luspatercept and ibotine alpha using the standard dose. And they were stratified according to their baseline transfusion burden, erythropoietin level, and ring sideroblast status. So the primary endpoint was RBC transfusion independence for at least 12 weeks, plus there should be a concurrent mean increase in hemoglobin by at least 1.5 gram per deciliter. This is the baseline characteristics in both groups, and median age was 74 in each group. Median hemoglobin was 7.8, and median baseline transfusion burden was around 8 units per week. 3 units per week. And what also they found that 60% they have SF3B1 mutation in the luspatercept versus 55 in the erythropoietin alpha group, not significant. And also what they actually noticed that majority of patients were actually ring sideroblast positive. So only 26% of patients and 27% in luspatercept and EPO group respectively, they are actually ring sideroblast negative. The primary endpoint was actually met with 60% of patients. They were actually able to achieve transfusion dependency for at least 12 weeks versus 34% in the erythropoietin stimulating agent group. And these responses seems to be identical across all the patient subgroups, whether those who have high transfusion burden or low transfusion burden, and also those with low erythropoietin level or high erythropoietin level, and also regardless of the mutation status, whether they are SF3B1 mutation positive or negative. However, except for ring sideroblast, the difference was remarkably clear, favoring the luspatercept group in the ring sideroblast positive. However, for ring sideroblast negative, which is again around quarter of patients, they were ring sideroblast negative, there was actually no difference in the outcome in the primary outcome between luspatercept group versus group who received the standard of care of erythroid stimulating agent. And also looking into the secondary endpoint, there were a maintained difference in favor of the luspatercept response, even for those who achieve transfusion dependency for at least 24 weeks. The same for the other subgroup for the 24 weeks. And the duration of response was actually superior for luspatercept versus erythropoietin. So the median duration of response was 126 weeks versus 89.7 weeks for erythropoietin alpha. And this duration of response was also maintained in the RS positive group, and also in those with erythropoietin level, baseline erythropoietin level, whether low or high. And also was maintained for those with high transfusion burden or low transfusion burden, or those with SF3B1 mutation or no SF3B1 mutation. In terms of safety data, there was no difference in terms of disease progression or AML transformation between both groups. And also there was no difference in other parameters. However, there was an increase in the fatigue with the use of luspatercept compared to erythropoietin alpha. However, this increase in fatigue, it's actually improved with time. The more exposure to luspatercept, there was a remarkable reduction in the fatigue with the more and more use of luspatercept. So currently, the luspatercept approved in the US and Europe as a first and second line, and it's approved as second line by the Saudi FDA. So now we're shifting gear into different intervention that I felt that is of interest to share with you. This is a study that is conducted by a Spanish group. They are looking into patient with 5q deletion low risk MDS, and looking into patient who are transfusion independent. So they are not requiring any transfusion. However, they want to test whether lenalidomide will affect the outcome for those patients and delay the onset of the transfusion dependency. So this is a multi-center randomized double-blind placebo-controlled trial. They enroll patients with low-risk MDS who are transfusion independent, but with hemoglobin of less than 12, and they have, of course, deletion 5q with or without any other abnormalities. And they randomize them to lenalidomide small dose 5 mg daily in a 28-day cycle versus placebo. And they want to look into the primary endpoint of time to transfusion dependency. And there was really a remarkable result seen where patients who received lenalidomide, actually they did not reach the median time to transfusion dependency. However, those with placebo, they actually reached the median time to transfusion dependency was 11 months. And this is after a median follow-up of 5 years. So after median follow-up of 5 years, median duration was not reached for lenalidomide. However, for patients who did not receive or receive placebo, the median duration was 11.6 months. Yes, the number is small, but really this is a provocative data. And what also was interesting in this study, 80% of patients who received lenalidomide, they actually achieve cytogenetic response. And we know from the previous data that achieving cytogenetic response in 5q deletion MDS was associated with improvement in the overall survival. Other intervention for low-risk MDS is the use of hypomethylating agent. Until now, the optimum use of hypomethylating agent for low-risk MDS is not well defined. Still, the area of finding the optimum dose is under investigation. However, different groups use different combination, whether decitabine for 3 days or azacitidine for 3 days of smaller dose or larger dose. It shows some percentage of transfusion independency and also some CRs, but of course, this is associated with some toxicity in terms of cytopenias and others. So area is still not clear, but this is a viable option for those who fail multiple line of interventions. The use of oral azacitidine has been tested in a randomized study versus placebo, where they enroll more than 200 patients randomized between oral azacitidine and placebo. There was 30% of patients were able to achieve transfusion independence using oral azacitidine. However, in general, the overall survival was actually not what you expect with low-risk MDS, and indicating that the baseline characteristics of patients were actually high risk rather than low-risk MDS. So it's not really clear whether the use of oral azacitidine for low-risk MDS will result in a significant improvement in the outcome. Another interesting data is the use of imetelstat, which is a telomerase inhibitor. This was tested in an IMerge study, which is a double-blind randomized phase 3 study where they enroll patients who are refractory to, who are transfusion dependent, low-risk MDS transfusion dependent, who are refractory to erythroid stimulating agent. They are non-5q deletion, no prior lenalidomide or hypomethylating agent, randomized 2:1 to imetelstat IV injection Q4 weeks versus placebo, with a primary endpoint of 8 weeks RBC transfusion independency. So the primary endpoint was actually met. Around 40% of patients with imetelstat, they achieve at least 8 weeks and more of transfusion independency versus 15% for placebo group. However, the problem with this intervention, there was a lot of cytopenia. So many patients required GCSF support in the imetelstat versus patient in placebo, and also platelet transfusion support as well. So yes, there was an improvement in the RBC transfusion, but other forms of cytopenia was actually remarkably higher in the imetelstat group, which actually might affect the approval for this intervention as an option for treatment of low-risk MDS patients. So in general, the algorithm for treating low-risk MDS is become more and more complex. But the good thing that we have a novel agent that can help navigate this complexity. In general, a patient with 5q deletion should receive lenalidomide if they become transfusion dependent for low-risk MDS. And although there are some data suggest now introduction of lenalidomide early on will prevent the disease progression. As we mentioned, luspatercept has become a viable option for newly diagnosed or newly transfusion-dependent low-risk MDS patient. We should also not forget that IDH1 inhibitor, ivosidenib, is actually approved also for patients with low-risk MDS who fail multiple line of treatment based on very small limited data for MDS patient with IDH1 mutated disease, which account around 5% of MDS patients. Patient with thrombocytopenia can be treated with the thrombopoietin TPO agonist, L-Thrombobag, for example, and hypoplastic MDS can be treated with immunosuppressive therapy, and if they fail, they can transition into bone marrow transplant if they are fit for that. With that, I conclude my talk, and happy to take any question. Thank you very much.
Thank you so much, Dr. Badr. Very comprehensive, nice presentation for overview of management of low-risk MDS. For the attendee, please, if you have question, either you can raise your hand and go ahead with your question, or you can post your question in the Q&A section in the right corner of the screen. Probably I will start with the few questions in the Q&A session, and there is like which drug do you recommend for immune modulation, and how effective is this?
I believe he mentioned he wants immune modulation. That means the use of lenalidomide, which is which is known immune modulating agent, and usually this is used primarily for patients with 5Q low risk MDS patient, and because a randomized study showed around 60% response rate, and you can achieve cytogenetic response that is associated usually with improvement in the overall survival for those patients. But also we can use it for other type of non-5Q low-risk MDS patient based on a randomized study that showed a response rate can reach up to 35% of patient with non-5Q MDS patient. So still considered to be a viable option. But of course, we use it usually for those who fail erythroid stimulating agent in the upfront setting. But still a viable option and can be used. Of course, you want to make sure that patient does not have any cytopenia in terms of neutropenia and thrombocytopenia, because in the studies, patients with platelet less than 50, they were universally excluded from these studies that use using the lenalidomide.
Okay, thank you, Dr. But there is another question about luspatercept and the effect of luspatercept reducing transfusion requirements. So probably the question is regarding the degree of response to luspatercept in low-risk MDS.
Correct. Yeah, as we mentioned, I mean, I've presented the data here that luspatercept was able to decrease transfusion requirement for patient in the relapse refractory setting and in the upfront setting as well. And those decreased transfusion requirement was durable compared to the other arm. So, yeah.
Okay, the last question here is maybe about the summary slide. What is the best treatment option as first line for low-risk MDS?
So low-risk MDS, yeah, I mean, it's I think based on the data, the first line would be luspatercept, if available, for patient with anemia and transfusion dependent. So luspatercept will be the best option for them. Erythroid stimulating agent still a viable option for those patients. So universally, low risk MDS is a support is you treat them in a supportive way. Depend on what kind of abnormality they have in terms whether this is associated with anemia more or thrombocytopenia, but in generally anemia. So this is how the approach would be. Supportive measure using the best agent to support the anemia for those patients with the use of luspatercept, as I showed that in randomized study was superior to the standard of what used to be the standard of care, which is the erythroid stimulating agent.
So there is a very interesting question, I think, by Dr. Ahmed Al-Askar regarding combining luspatercept with erythropoietin stimulating agent. So probably erythropoietin work in the proximal side of the erythropoiesis and luspatercept in the distal side. So is there any studies or data on the combination, or do you think should be tried even if there is no data giving biological evidence?
Yeah, currently there's no data to say that you must combine the ESA with luspatercept, right? However, I think in practice, many people, whenever patient lose the responses for ESA, they might increase the dose and reintroduce the luspatercept for those patients. But yeah, I mean, there is no specific data to mandate the combination of ESA with luspatercept. But yeah, that may make sense biologically, probably.
Okay, so I think I have two more questions. Maybe then we will conclude. This question is: do you think randomization between LENA and placebo and 5Q is fair one? So as the standard of care would be erythropoietin rather than placebo. You hear the question, Dr. Badr?
Is this regarding the Spanish study that I just mentioned?
Yeah.
Yeah, because those were transfusion independent, so there is no point from giving them erythropoietin in the upfront, because the aim is whether achievement of the cytogenetic response would result in better outcome, because we know that lenalidomide is disease modifying. You were able to achieve cytogenetic responses for low risk MDS with 5q deletion. But yeah, I mean, we can argue that why not to give erythropoietin for those patients, but it's not the standard of care to give erythropoietin who are not transfusion dependent low risk MDS. So it's not, I don't think it's an ideal to give them ESA if you want to test the efficacy of lenalidomide.
Okay, so I think one last question about ATG, use of ATG in MDS, especially what type of ATG and the safety profile of ATG.
Yeah, I mean, this is a very rare subset of patients. Those with hypoplastic MDS, HLA-DR 15. So it's really a very rare subset of patients that they come like hypoplastic MDS with cytopenia. They're mimicking the aplastic anemia, but they do have dysplastic changes or genetic mutation that qualify them for MDS. And I think the standard of care, we should do transplant for those patients if they have a donor available for those patients. But sometimes it's not an ideal to do a transplant for those patients for a reason or another. So ATG would be the next viable option for those patients. ATG, it carries some risk, of course, risk of infection and infusion-related reactions and others. So it's not completely safe to introduce ATG for those patients. I don't have the right options answer whether to use horse as we do in aplastic anemia, because actually there is no evidence to support for this specific subset of patient you should do this or that.
Okay, thank you. So I still see some questions coming up. So these questions, I will combine them in one last question. Regarding luspatercept use, the target hemoglobin you want to reach, and risk of thrombosis. What about the dosing of luspatercept according to the study? And what's the threshold for transfusion? So probably you can comment on these points before we conclude this meeting.
So so you want the hemoglobin to go to the level that will make patient comfortable, right? In general, for the dosing, there's a dosing schema that you start the 1 mg per kg for it's every 3 weeks. For you do it for 2 doses, and if they achieve transfusion independency, which is in general, you want to transfuse anyone below 7, right? Hemoglobin of 7 or 70. And however, if they have like cardiac disease, you have to have a higher threshold for the transfusion. I cannot remember what was the definition actually and what level you will transfuse within the study. But in general, if you dose patient with luspatercept, if patient achieve hemoglobin of 11, so you need to go down on the dose or hold the dose sometimes. So it's not recommended to exceed hemoglobin level above 11 for those patients with luspatercept. Risk of thrombosis, as I mentioned, in the 2 randomized study for the relapse refractory and in the upfront setting, there was no significant difference in the risk of thromboembolic event between both arms.
So thank you so much, Dr. Badr. Very nice presentation and nice discussion session. And at the end, I would like also to thank Saudi Society of Bone Marrow Transplant for arranging this very useful series of activity. Great thank to Dr. Badr Al-Ahmari. Great thank to Bristol Myers also for sponsoring this meeting. Great thank to the Noor, Secretary of SSBMT and the technical team. And I will leave the floor for BMS if they have comment, or Dr. Ahmed Al-Askar also if you want to.
No, thank you all. Great session. Thank you, our panelists and our attendees, and see you soon in another webinar of the SSBMT.
Thank you very much.
Thank you.
Thank you.
Good night.